Hi, everybody. This is Andrea Gallagher. I'm the president of Senior Concerns, and thanks so much for coming today. This must be a very popular topic because we have capacity for 100 attendees, and we had over 115 or so apply. So we are going to try to record this session, and we will post it up on our website with Carlo's permission. And so if you want to review it again, you can do that. And if you have friends that you think might like to take a listen, we'll have that available for you. And I really want to thank Dr. Reyes for agreeing to be a part of this today. I'm going to ask all of the attendees to stay on mute. Dr. Reyes will take questions. But what we'll have you do, if you have a question, if you could type it into the chat section, and then I will bring those questions up to Dr. Reyes as appropriate, or he might stop after a certain section that he talks about and ask if there are any questions. We do apologize in advance if all questions don't get answered because we do have 100 people on this call today. This presentation will last exactly 1 hour. And as I mentioned, we're going to record it and put it on the Senior Concerns website. So let me introduce our keynote speaker today. Dr. Carlo Reyes is the Vice Chief of Staff of the Emergency Department at Los Robles Hospital and Medical Center. And Carlo, please correct me if I get anything wrong here. He is one of the most amazing individuals I have ever met. This man is an attorney. He's an entrepreneur, he's a pediatrician, and he runs the emergency department at Los Robles Hospital. I don't know how and a father, I don't know how he has time for everything that he does. We had the opportunity of Martha Shapiro and myself, who's also on this call today, to listen to Dr. Reyes talk about this topic with a bunch of healthcare professionals about a week ago, and it was so valuable that we really thought it was important to ask him if he could come address those of us that are on this call today. So without further ado, I will introduce Dr. Carlo Reyes, and it's all yours.
Well, thank you, Andrea, for that kind introduction. It's a pleasure to be here to talk to you all. I know that there's lots of questions. This has been probably one of the most trying times probably in human history, considering everything that's happening. And but I think the first thing to say is that COVID-19, we are still in the middle of it. Just because places are opening up and we're able to get out a little bit more doesn't mean that COVID-19 doesn't exist anymore. But I think that the initial months, the beginning months of this, it gave us some time, the stay-at-home orders gave us time to really understand the disease, understand how we could protect ourselves and be safer. Whether it's, nurses and doctors in the hospitals moving to grocery stores and how to keep safe there, to now pretty much everywhere we go, we have to consider making good decisions to stay safe. Interestingly enough, Ventura County is kind of noted as one of the, I guess, safest counties. We were one of the first ones to allow to open restaurants, etc. And I think it's because we've been safe generally. A lot of us have made good decisions as a community, but we need to continue to make good decisions. And so I'm here to help answer some questions as we kind of open our doors and start to experience society again, so to speak. So I came up with several questions that I think are common questions that everyone has. And I have it organized based on slide. So the first question that I pose, and before I move forward, I want to say that you're going to have some questions, and please feel free to type into the chat box as soon as you think of it. And feel free, Andrea, to interrupt me because I do want to answer questions, but I hope that the way that I present this will answer most of them without having to ask the questions. So the current state of COVID-19 in Ventura County, where are we? Okay. The whole reason why the stay-at-home order was so important was so that, well, obviously we want to prevent, people from dying, obviously. But we learned from other places like Italy and New York that we really wanted to be careful about our resources, our healthcare resources, whether it was ICU beds and ventilators, doctors and nurses and respiratory therapists, were all resources in the healthcare field. And if any of that were to be threatened in any way, then we wouldn't be able to keep our communities healthy. So we really had to look at how to make sure that we can keep track of our ICU bed capacity and the incidence of admissions of COVID-19 infected patients. And so that was the beginning. That was really the focus of the stay-at-home order, was to make sure that we weren't over inundating our hospitals. And if anyone, and it was in the media about how badly Italy was hit, and then New York was pretty badly hit, and Italy, they were well beyond their capacity to care for patients, and there was a lot of mortality related to that. In New York, there were similar stories, both anecdotally and in the news, about how, they were running out of, ventilators potentially, ICU beds were scarce. And so we actually had the benefit of learning from other places, what can we do to prevent that from happening? And so the stay-at-home order was that. And I think that Ventura County specifically did a very good job. Driving around, there were very little cars around. People were staying at home, and that was good. And so now here we are, a couple of months later, we have an understanding, we have ways to prevent the transmission of COVID-19 by implementing new practices to protect ourselves, to protect our patients in the hospitals, for example. So it really impacted how we treat patients in the hospital. We cohort patients in the beginning. So when patients come in, before they even enter into the building, we ask key questions, and you'll see things you've never seen before. You see ER physicians and nurses coming outside to see patients, so that we could really understand why they're coming to the ER, what's going on, because we really make it a focal point to try to separate patients that might have COVID from patients that don't, or likely don't. There's been this kind of fear of ER, or fear of hospitals early on because of COVID-19, and I think the workflows that we implemented really made it safer, so that people wouldn't get exposed, or the risk of getting exposed in an ER was very low. And in fact, I feel safer in my ER. I don't want to say it that way, but I feel safe in my ER, whereas when I'm at a place and it starts to get crowded in a place, I don't know who the person I'm standing next to, if they've had it or just recovered from it, and who knows? Do you see what I'm saying? So that took a lot of effort in the beginning for us to find ways to make things safe for patients, to make things safe for myself and my fellow doctors and nurses and respiratory therapists, et cetera. And I think we've gotten there. I think all the hospitals have pretty much gotten there. So that's changed the way we treat patients, and we initially evaluate patients in the ER. Currently, there's a website that looks at the daily rates of hospitalizations, incidents, mortality of COVID-19. If you were just to Google COVID-19 incidents, and one of those, it would actually pop up. And so, and then we get updates every day on how many patients we have. Right now, as of today, I believe we have, I think we're in the 40s in the whole Ventura County, 40s or 50s in the ICU. And we have way more beds than that. So we're doing okay. When the stay-at-home order was initially implemented, and when our census was down like 60%, there was a point where we only had 5 COVID ICU patients in the whole county, for example. So on one hand, we're still doing a good job, but as you can see, when we start to open up a little bit, there will be more cases of COVID-19, because like I said, it's still around, it hasn't gone away. So to answer the question, the current state, I think we're doing good, we're doing well. But again, those good decisions about taking care of yourself, washing your hands, and we'll talk about masks and other things, but I am definitely a proponent of wearing masks. Whether you're, say, the asymptomatic COVID patient, where Some people can be asymptomatic and potentially transmit. We could talk about that as well if people have questions about that. It's probably rare, but it can happen. Or whether you're immunocompromised or have chronic illness or have primary a lung condition. There's so many reasons to try to protect yourself currently with COVID-19 around that. Masks are a vital part of what we need to do moving forward during the pandemic. So we'll talk about that as well. All right. So I did touch upon this initially about what our clinical approaches are in the treatment, diagnosis and treatment of COVID-19. And we'll talk about current treatments, where the vaccine is, for example, if there's any other treatments as well. And I actually didn't mention this in my last talk, but we'll talk about convalescent plasma as well. So anyway, in terms of triage and hospital care, currently in Ventura County, if a patient has COVID-19, but is very mildly affected by it, maybe a mild cough, but your vital signs are fine, your oxygen saturation is normal, you're not in any distress, you just have maybe even just a mild flu-like symptom. And again, keeping in mind that COVID-19 can present in a very mild way, or can present in a very severe way. But the vast majority of people present in a mild way, okay? And I've seen many of these patients that probably have COVID-19, or let's say they were diagnosed with it and became concerned, came to the ER, and then we did our assessment, our vital signs, we did additional testing, and everything looked fine. We would send people home that had COVID-19. And the reason why we could do that is because at that moment, they're not looking ill. They'll probably recover from it fully. But we tell patients, look, if you start to feel worse in any way, if the pain becomes more severe, if you start breathing harder, then definitely come back, So yeah, all of us have, this is every ER in the country, if a patient has COVID-19, or let's say they probably have it, we say, look, you might have it. We're not going to test for it today. But we ask for you to quarantine yourself for 2 weeks because you probably have it, or you do have it, and then return if you feel worse in any way. So that's, people may have some preconceived ideas of it. Oh my gosh, I have COVID-19, I need to get admitted. And that's actually not the case for the majority of COVID-19 patients. Like I said, the patients are cohorted at triage. And importantly, there's visitation restrictions in most, if not all, hospitals in California. So, for example, where I work at Los Robles, unfortunately, a patient's family and loved ones can't come in with them as we evaluate them if we think that they might have COVID-19. But we do our best to reach out to them. We get cell phones, we talk to them, give them updates, things like that. This is a very trying time because obviously, you're dealing with a condition that might cause severe illness. You don't know, and then you're bringing your loved one to the hospital. But at the end of the day, this is really to protect everyone. We don't want people to unintentionally get exposed to it. We're still seeing anywhere from 120 to 140 patients a day. And you could imagine if each of them brought family members and loved ones, all of a sudden you have lots of people going back in and out of the ER like we used to. And we want to limit, if not completely avoid, a contraction of COVID-19 while just being in the hospital, visiting a friend or family, that type of thing. In terms of treatments, it's mostly supportive, actually. There's been a lot of talk about medications, and again, it actually gets into, I'm not going to get political about any of this. I think that COVID-19 is a medical condition and not a political stance, quite frankly. But at the same time, there is science behind what we think works and doesn't work. And the unfortunate thing is that most of the treatment out there, the initial treatments, the oral medications actually flatly just do not work. There's some experimental medications that has been shown to help, and it's a medication, remdesivir, I believe his name is, and it's used only in certain situations, but it just shortens the duration of the illness. So if someone has it, they have it, it's not going to eliminate it, it's actually going to shorten the course of the illness. similar to the treatment for influenza. Doesn't cure it, but it actually shortens the condition. The problem is that when some conditions are very severe, these medications are not a silver bullet. They're not going to eliminate the infection. So we certainly don't have that. Fortunately, the treatment is mainly going to be supportive. It's going to be oxygen therapy. There were some initial treatments. What's so unique about COVID-19 is that there are some common ways in which we treat conditions that we thought would work for COVID-19 in the beginning, and they didn't. So putting someone on a ventilator very early on, for almost every other condition, if someone has difficulty breathing and they need to be put on a ventilator, it doesn't necessarily make the condition worse. But it appears that with COVID-19, putting someone on a ventilator potentially could make things worse for them. So we've modified the way that we evaluate patients that have difficulty with breathing. We have alternate modalities to treat it. And I'm happy to say that we found a fair amount of success in the different approach in which we treat COVID-19 in the hospital, especially for those patients that are having oxygenation problems, et cetera. In terms of vaccine, let's talk about vaccine. The unfortunate thing about vaccines are that we're pretty much nowhere near a vaccine, and it may take this next flu season, meaning well into 2021, before we could actually maybe have enough testing done to confirm that there is some efficacy in it, and then be able to launch it widespread into communities. So as we go into the 2020-2021 season, we most likely will not have a vaccine. So what impact does that have? Well, I think that what we're going to see is that we're going to have a heightened sense of concern and vigilance all the way through the summer for sure, but even more so as we get into the next flu season, because it is thought that the coronavirus is a seasonal illness, causes seasonal illness just like influenza. So with the idea that the activity and the incidence will go up as we go into the winter months. The vaccine is important because it's a way in which we can get what's called herd immunity. Herd immunity is the idea that enough people have been infected by the virus so that it confers immunity to the rest of the population. Because that means is that the transmission gets so low because 80%, 85% have already been exposed to it. So it just can't continue to transmit at such an alarming rate, which is what we're seeing with the current state of the pandemic. So what a vaccine does is it kind of fakes the virus out by showing that, look, everyone has it already, and so that the transmission rate goes down. That's just kind of a simple way of thinking about it. Without the vaccine, the only way to get herd immunity is for everyone to truly get COVID-19. So that's a problem, because I think that would cause far too much morbidity and mortality. So that's why the stay-at-home order becomes important. And I wouldn't be surprised if the stay-at-home order might scale up and down depending on the incidence and utilization of hospitals and ICU beds changes. So although we're kind of loosening things up now, we're in June, the coronavirus activity might get lower and lower during the summer months, but it's still significant. But in the back of my mind, I'm wondering, are we going to actually kind of scale up ramp up the stay-at-home orders, September, October, November, if these numbers start to climb at a rate at which we think we won't be able to keep up with regards to taking care of patients in the hospitals. So that,
Carlo?
Yeah, go ahead.
So one of the questions that I had early on was, have rules for seniors changed since we are entering stage 3 versus the original stay-at-home order?
I would say that the rules have not changed because, and this goes, let's kind of clarify. I would say anyone that has certainly multiple comorbidities, they have, say, some type of immunocompromise, that they are on chemotherapy, or they have a cancer that kind of limits them in terms of their immunity. those types of conditions. Or let's say they have primary lung problems like COPD, advanced asthma, emphysema, that type of thing. These are the conditions that put people at more risk for more serious, severe illness with COVID-19. So in terms of that population, I think that when I say the rules haven't changed, what I mean is there needs to be an extra sense of caution for them. I think that I have parents who are in their mid-80s, and I tell them they should try to stay home as much as they can. If they, they have family that can help them with groceries and things like that. I think that if you go out, then you definitely have to wear a mask. I think that being very careful about where you go, certain places are just going to be much more crowded. I worry about, kind of tangentially related, I worry about the bar scenes because there's going to be very packed. How are they going to keep that under control? That's the reason why they're not allowing fans going into sports activities right now, or viewing sports activities right now, things like that. So to answer your question, I don't think it has changed. I think that just need to be super vigilant. And I think we all need to understand that if we think that we have a mild cold or we might be sick, that we should be careful. We should preferentially stay home instead of going out. And, even if you have a, low-grade fever, or let's say you had a cough, that's different now. Before COVID-19, people would still go out and, parents of kids would still send their kids to school, even though they had fevers and coughs and runny nose. That's all going to change. It all should change during this pandemic. Does that answer the question?
I think so. A corollary to that is someone's asking if people are staying at home, and I think there may have been some direction, I don't know, maybe that older adults, say 75 and older versus the original 60 and older, are really still being encouraged to stay at home, even if just it's an age element versus having other chronic diseases. But one of the questions someone's asking is, well, if we're all staying at home, if we're older, do we need to get a flu shot this coming year?
Interesting question. I think the general answer would be yes. It brings up an interesting point, and this is a point in pediatrics, is that there are a lot of pediatric patients that are missing their vaccine status because of the stay at home. So you have this large amount of kids that are missing their vaccines, so they're not as protected, so they're behind in their immune status, immunization status. Similarly, I think that could happen with influenza vaccines, right? Because influenza is not going anywhere either. It's still seasonal. We see it every year. And the bonus is that we have a vaccine that has reasonable protections against influenza, So I still think it's vitally important to get the vaccine for influenza, regardless of what COVID-19 is doing. It's a different virus, and you can get infected from either or both at the same time.
Great, thanks.
Yeah. Okay, so so that gave you a little background in terms of the medical part of it. And I think that one thing I wanted to bring up was the idea or the importance of advanced care planning. So by advanced care planning, what I'm referencing is talking about goals of care, talking about people's treatment wishes. And it becomes more and more important when people have evolving progressive chronic conditions, and then even more important when those chronic conditions become terminal, when someone has cancer or severe illness and they're constantly at risk for serious disease or infection or progression of their condition. And what I've noticed with COVID-19 era is that there's special challenges, right? Because we talked about how there's no visitation in the hospitals now, so it's hard to communicate with family members about people's conditions. And it really has impacted how we communicate with our patients and their family members, to the extent that I worry that doctors and patients and families are not communicating as well because of these additional barriers that we have to acknowledge, because people are not able to come into the hospital, or family members and friends and loved ones aren't able to come in. And so that poses a problem. That's the one thing about advanced care planning, more like a technology or workflow kind of barrier. The other issue is that there is, in a way, two types of COVID-19. There's the COVID-19 that's causes mild to moderate illness. Okay, the vast majority of people that get COVID-19 get that type. But there's another type of COVID-19 where people get sick very fast. And that's the one that was really hitting media, television, social media about how alarming the more rapid version of COVID-19 is with regards to progressive illness. And we saw this a lot in Italy and in New York. And when COVID-19 first came out, I saw it myself in the rapid decline of patients with COVID-19. And so that made me think of the idea that a person can be reasonably healthy, not thinking about their own treatment wishes because they feel okay. And then if they were to get the more progressive version of COVID-19, they could be very sick within a day and then be in the hospital in the ICU that night. And by the next day, they're very, very sick. And we've all heard and read and seen some of these tragic cases of people dying within a day of being diagnosed. And so I bring up the idea of advanced care planning because it's so important. And COVID-19 actually makes it more important that we all talk and understand what our treatment wishes are. We talk to our loved ones, we talk to our parents, our brothers and sisters, just so that we know. And I think that advanced care planning is important for that very single reason, that we would want to make sure that whatever it is a doctor provides treatment is in alignment with what that person wants to happen. I mean, that's the whole purpose of advanced care planning. I talked to my parents about it. I know the scenarios in which they would, what type of care that they want, things like that. They actually know what my wishes are. My kids know my wishes because we all talk about it, And so I think that there's an intellectually interesting corollary about how COVID-19 has really brought about the importance of having discussions about what treatment wishes people have, because COVID-19 has really brought up some interesting barriers, and it's a very unique condition. If people say that this is just like the flu, then they really don't understand COVID-19. And I want to stop there to see if anyone has questions, if they have questions about advanced care planning or anything.
So I had a couple of other questions, and I think you might address this later, but since it's out there, we might as well address it now. Someone is saying that some of their clients that they work with have been avoiding surgeries, needed surgeries or things that they should be having done because of the fear of being in the hospital. Can you address that?
Yeah, and it's the bigger question. It's the fear of hospitals generally, right? So we'll talk about procedures and surgeries, et cetera. There's two types of procedures and surgeries, right? There's the one that you need to do right away because it's an emergency and it just needs to be done. And then there's the kind of planned procedure, elective procedures, those types of things. So I'm going to answer both those questions in the context of the safety environment that healthcare has created in response to COVID-19 first. And what I mean to say is that, remember I was talking about a little while ago about how hospitals throughout the country had to change everything, their workflows. They had to understand how to make not just their patients safe, but their doctors, nurses, respiratory therapists, anesthesiologists, everyone around the patient had to be safe too, right? You have to protect the patient and the healthcare system in order to continue protecting and saving and helping patients, right? So I think we've achieved great strides in doing so. So when it came time for hospitals to be allowed to have elective procedures, I think that before that we were working hard at finding safe ways to do the things that the procedures that we need to do. So to answer the question in that context, if you want or need a procedure, meaning if it's elective or emergency, hospitals have, and I'll speak for Los Robles specifically, but I'm hopefully and I'm virtually certain that all hospitals have done this, that we've all created different ways in which we protect ourselves and protect our patients. We do a lot of pre-op. We do COVID testing pre-op, for example, just to make sure that you didn't inadvertently get COVID right before your procedure, that type of thing. There's extra precautions for anesthesiologists and surgeons, for example. They gown up, they wear machines on their faces to prevent them from being infected. So there's a lot of different ways in which we protect ourselves and our patients, which would make it safe to not only be in the hospital, but to have a procedure done. The second thing I want to bring up is the idea that early on, people were so afraid to go in the hospitals that they refused to come into the ER, even if they were seriously ill. So like I hadn't seen things, in years that I've just seen in the past month, like heart attacks that fully completed themselves and now they're in end stage congestive heart failure because they had chest symptoms, but they didn't go to the hospital. Strokes that were fully completed. And, when you come to the hospital for a stroke or a heart attack, and it's been more than a few hours and certainly more than a day, there's much less that we can do to help reverse that condition, that acute condition. So there's a time-sensitive element to strokes and heart attacks and sepsis and infections that is so important. Coupled with how safe I believe emergency departments and hospitals now are, I think it's safe to come to the ER if you feel that you need to come. But it's been sad because there's been some cases where people came to the hospital and there was not much we can do because the patient came in too late. All right, that was kind of a long-winded answer to your question.
Thank you.
Any other questions?
We're good for now.
Okay, so let's talk about reopening status. We touched on it a little bit. And it's interesting because when the different phases were introduced, people were asking questions about, wow, is this going to take months to happen? How long is it going to take? But as you can see, it was a pretty quick ramp up. In my opinion, it seemed pretty quick to start opening places up. People ask me, this is probably the single most asked question of me, do you think it's right that we're opening up? Or do you think it's safe that we're opening up? Which are actually two different questions. Do I think it's right? Yes, I think it's right. I think it's important. I think that we can't be, our communities can't be closed for much longer. There are many other issues, whether it's, obviously there's financial issues, there's businesses that are closing, there's the mental health issues, the isolation issues, or the social isolation issues are very significant actually. So for a lot of reasons, and especially since we feel that we have at least an understanding and an approach to dealing with COVID-19 in the hospitals and a means to track it, because we have those now in place, which we didn't have a few months ago, yes, I think we should open, but I think we should maintain that vigilance, and we should still acknowledge that our government can and should scale back the opening if the numbers start to show a concerning trend. Next question, is it safe? Well, it's safe insofar as we are safe, right? Because it's interesting that COVID-19 has a lot to do with human behavior. If I'm sick and I stay at home, I'm doing the right thing. It's actually a civil duty now. It's becoming a civil duty for me to stay at home and to think about my society, about hopefully not infecting someone else. Okay, so there's the societal good that if you feel sick, you shouldn't go anywhere. You should stay at home. If you're exposed to someone and you feel great, if you're exposed to someone that has COVID-19, but you feel great, it's actually your civil duty to get to quarantine. That's the CDC recommendation, even though you feel fine, you know. I self-quarantined myself when I came back from India on a medical mission. I was actually almost stuck in India on a medical mission because COVID-19 exploded literally while I was in India. So I didn't know, like, was I going to get it on the plane? I was barely able to make it home. But because of this uncertainty, I quarantined myself for 2 weeks. I certainly didn't want to come back to the ERs and ER doc and start treating patients unwittingly infecting other people, you know? So it is a civil duty. So from the human behavior standpoint, if we all do the right thing, then it is safe. The other thing to point out is that not only have hospitals have implemented safe workflows, it is the duty of restaurants and malls and now gyms. All of them are supposed to implement safe standards for reopening. Are they all doing that? I don't know. But I think that knowing where you go and looking at their approach to what they do to maintain social distancing, because keep in mind, even though things are opening up, the social distancing is still required. I mean, it's still recommended, if not required in a lot of scenarios. So we still need to maintain social distancing. We still need to wear a mask if social distancing is very difficult or impossible. So if you lived in Manhattan, how could you possibly social distance? And that's one of the reasons why New York was so difficult in terms of COVID-19 early on. And then I want to bring up the protests. From a medical perspective, obviously from other perspectives, this is like almost of biblical proportions what's happening to the globe right now, coming from the pandemic to the civil rights movement. Probably the largest civil rights movement in the history of the world right now is happening when you consider that every country is involved now. We could see what everyone's response is to this movement right now. My concern is that you see these pictures of these protests where they're really shoulder up against each other, you know? And so I worry about, is that going to induce a spike? Possibly, if not probably. There's another question that has been posed. If you participate in a protest, should you quarantine? Actually, probably, you know, but is anyone truly quarantining themselves in this scenario? Probably not. So that's why I bring back that it's interesting how COVID-19 it turns into a kind of a human behavior analysis, and how this pandemic could stop in a month if everyone did the right thing, quite literally. But we know that's not going to happen, right? So, but I think that on an individual basis, we could all be responsible for our health. We could all try to make the best decisions. We could be very careful about who we interact with. I tell my kids that. I say, look, ask them the questions. What are you doing? What type of activities are you doing? You know, and if it sounds a little bit, you know, on the fringes, so to speak, I tell my kids, don't hang out with them, you know? So that's the reopening status. I think we're opening up. I think it's important to open up for a lot of reasons, but the social distancing objective should still be in place, whether it be physically social distancing, masks, or just literally staying home if you're not feeling well. I'll pause for questions.
So one of the questions I have is there any research on masks being detrimental to children and or adults? I know we've heard about gloves and how people wear gloves and they have this false sense of sanitation when they have gloves on and they're touching their face and touching everything and they've got COVID all over them.
Yeah, look, it's just, that was perfect segue to this slide. So the importance of cloth, surgical masks, sanitizing hands, etc. So yes, there's been a lot of information on this. And the general idea is that an N95 is sufficient to protect particulate matter. It's, you know, the size of a virus, for example, from entering, from passing, so that you could be protected. Okay. The problem is that, you know, when I was in med school, and certainly nurses and anyone in a hospital is working, we're kind of taught how to use N95s, taught how to use gloves and gowns, and it's called universal precautions. It's the idea that we don't want to contaminate ourselves, and so there's a way in which to do it. But if you don't understand how to wear the gloves and how to wear the mask, then they become completely futile and pointless. The reason being is that these the COVID-19, or the coronavirus, the novel coronavirus, can potentially stay on surfaces. So if a coronavirus is on a surface, right? Let's say you have your gloves, and let's say you're ready to do something, you touch it, right? And now it's on your glove, okay? Well, what normally we would do is, once we're done with whatever activity we're doing, we remove the gloves carefully, we wash our hands, and then no more coronavirus. But what we're seeing is, you know, out in the community, people are wearing gloves all day, they're eating a burger, they're smoking, they're holding, you know, at this point, it makes no difference. You're just cross-contaminating everything, and the gloves do absolutely nothing. When you remove it, you're still doing this, and it's, you know, it's all over the place, right? So the better recommendation for gloves is just to not wear them at all, and just to frequently sanitize, okay? If you use a hand sanitizer, and I think it has to be over 70% or something like that, you know, pretty high percentage alcohol, then you should be fine. It's actually very easy to sanitize these viral particles and get them ineffective by cleaning your hands with sanitizer. So very simple. The difference, and so that's the story with gloves. I think it is counterproductive entirely. I don't think that gloves are necessary in any scenario because we know that people that don't know universal precautions are just using them incorrectly. The other thing is, a question I get is about cloths versus surgical masks versus N95 masks. So there is varying levels of protection, okay, between those three different types, okay? But people were surprised when I was first like going on social media, talking to friends and family about the importance of cloth gloves or cloth masks. And the reason why it helps is because it tends to protect you, or protect a person from your secretions, okay? So let's say that I have a mild cough and lo and behold, I have COVID, right? If I didn't have any barrier whatsoever and I sneezed or coughed, then those droplets would spray everywhere and potentially find someone else, and then you can get infected, right? But even if it's just a cloth mask, it would prevent a lot of that spray from getting past the cloth. And that would confer a substantial amount of protection. And then if you go from cloth to surgical and surgical N95, increasing protection. But if two people were wearing cloth masks, right, then that's a double layer between two people. So you could see how that would confer a substantial amount of protection for either person if either one of them had was infected with COVID-19. So in summary, even cloth masks are very helpful. Ultimately, since we're dealing with such a shortage in some of this protective equipment, N95 really should be reserved. And I was even asking for donations of N95 as stockpiling to make sure that our healthcare workers had enough so that we could protect ourselves when we treat patients that might have COVID-19. Does that answer the question?
That's great, yes. If you, and you may cover this later, but I'm getting a lot of questions about assisted living facilities and skilled nursing facilities. What should be the protocol? Are there different protocol for skilled nursing facilities versus assisted living facilities? What about visiting? What about a concern that your loved one's in a facility that has COVID? Maybe you can talk about that a little bit.
Yeah, very challenging. I'm sure that some of the audience is aware of the predilection of COVID-19 for our elderly and certainly for patients that are in skilled nursing facilities. These are patients that are have a lot of comorbidity, maybe some chronic lung conditions, heart conditions, et cetera. So they're a vulnerable population, and that's primarily I would say that I would imagine, and I've seen in several of the nursing facilities, there are some visitation restrictions in the same way that there are visitation restrictions in hospitals. I would also say that this also creates barrier problems in terms of communication, finding out how your loved one's doing. It's the same barriers that we have in hospitals. The difference is that a hospital stays, hopefully no more than a week, right? 5 days to a week, versus at a skilled nursing facility, it could be, obviously, indefinite for some time, sometimes indefinite, but certainly weeks, if not months. I think that what I would recommend ultimately is to reach out to the facility coordinator and administrators of the facilities, try to understand what their additional precautions that the facility has taken to make sure that there is no cross-contamination between patients and things like that, and that everyone's being held to actually a very high standard. Admittedly, before COVID-19, sanitation standards were not as high because it quite literally didn't have to be as high, but nowadays it's such a high standard that I'm going to give you an interesting statistic. The incidence of hospital-acquired infections in many hospitals has gone down dramatically since COVID-19. And the reason why is because we've implemented so much heightened sanitation standards to prevent cross-contamination and subsequent infection, for example. And so that's the level of sanitation that's needed in all facilities, basically. You're going to see the same thing in restaurants. I mean, they're implementing all these different approaches to trying to make sure that the food that they cook you is going to be, safe, that servers and cooks and chefs are wearing masks and things like that. And that's all for the good. But I think that the skilled nursing facility situation is a challenge. It always has been a challenge, and it continues to be a challenge. And it's probably more of a challenge with COVID-19. There's an ombudsman that could, that can respond and hear concerns, et cetera. And I think that utilizing that would be an important important tool as well, if necessary. But yeah, I feel for the patients and residents of skilled nursing facilities, because the statistics of the kind of predilection of infection and contraction of COVID-19 is pretty staggering.
Okay.
Any other
We've got
questions?
about 7 or 8 more minutes. I didn't know what else you wanted to cover there. Yeah.
Yeah, I could just say a few things about interesting things about COVID-19, and I actually didn't make this slide at the last talk, but I'll speak a bit about this. And it's something that I referenced the last talk previously, is the idea that we stand at such a benefit because we have seen the worst of COVID-19 in other places. So Italy was just horrific what was happening there. And partly because they just were not equipped, partly because they were probably one of the first places to get it. And so no one knew the severity of this virus and what it could do. Partly because there wasn't a high enough density of critical care access, critical care hospitals that could manage these patients. And so we saw a lot of death due to COVID-19 in Italy. We saw a fair amount of it, a lot of it in New York as well. Mostly because of the population density in New York. There's lots of hospitals, lots of specialty care, et cetera. So it was actually the mirror opposite of Italy. So Italy didn't have as much. New York had many hospitals. You can go 2 blocks and get to another hospital. But because of the population density and because of other factors, socioeconomic status, the fact that people couldn't social distance, the fact that people were too poor to not go to work, so they went to work anyway. For whatever reason, the COVID-19 spread like wildfire in New York. And with that, we got to understand the illness at its worst. We got to see how to treat conditions. We changed standards in how to treat COVID-19. There's many trials now in relation to whether it's a vaccine or a medication treatment. And those trials can only be tested because of the incidence of the disease. If there's a low incidence of disease, how do you test it? How do you test a vaccine or a medication, right? So, so we've benefited in so many ways from other countries and other states on how to manage COVID-19. And so the thing that bothers me is when people don't understand the severity of what COVID-19 can be, only because we live in a county where the incidence is very low. But we can't forget, just because we had a low incidence doesn't mean that COVID-19, it could have been a different story is what I'm saying, you know, and Ventura County could have been hit incredibly hard. And we didn't know the first month what we were going to do, what COVID-19 was going to do. So we are interacting with other states and other countries to understand what COVID-19 does. So the amount of information about COVID-19 is going to continue to expand over the next 6 to 12 months so that we get to a point where we'll understand how to treat it and how to prevent it.
Okay. Other closing comments you'd like to make? There's one of the questions that somebody did ask is, how can they hear this again? And so our website is seniorconcerns.org, and give us a couple days to get this up. I'd say by Monday or Tuesday at the latest of next week, we'll have it on the website. So seniorconcerns.org. And then I just wanted to, if there's a few extra comments that you want to make, Carlo, and then we had a couple of announcements we wanted to talk about.
Sure. I think in closing, what I'd like to say is that everyone just try to stay safe. Reach out to Senior Concerns. I'm happy to actually answer more questions if you need questions answered from a doctor. I think we're going to do fine in Ventura County. And I appreciate all the support. There's just been such an outpouring of support for everyone in Ventura County, and I especially appreciate all the thoughts and prayers for the frontline providers when we were, having some difficulty in the beginning. So thank you.
Thank you very much. I really want to thank you, Dr. Reyes, for taking the opportunity and the time to address some of our folks that are on the call today and to answer a number of questions. I do want to, there's a corollary to this call, and we are going to have another seminar, another Zoom seminar, which will be Thursday, July 9th at 4 p.m. And we are going to have 2 speakers. I guess I would call this all about COVID preparedness, meaning that we're going to have Terry Helton, who's a registered nurse, and she's going to discuss end of life and what matters most to you. So for instance, if you're not fully certain about what you think your wishes would be, this is a great conversation for you to listen to, and she'll talk to you about the documents. Dr. Reyes talked earlier about making sure you have your documents in order, and Terry will talk about that. We have another Terry Hilliard-Olson on the same call, who's an estate planning attorney, and she's going to talk about the estate planning documents that you need to have in place that are going to protect you and your family during the pandemic. So again, that is Thursday, July 9th at 4 p.m. and you will continue to register by actually go to info@seniorconcerns.org, info@seniorconcerns.org. Just tell us that you'd like to be registered for that call and we'll make that happen. I also want to tell you on a little bit of a lighter side that Senior Concerns has started a Zoom birthday party. So I just recently, I don't know how many of you read the Acorn, but my Acorn column for today in the Thousand Oaks Acorn talked about my little nephew that just had a 1-year-old birthday. And of course they did the drive-by birthday party for him and people handed presents to him or his parents, and the parents sent everybody off with a bag with a hot dog, a bag of chips, and a soda and a piece of cake. So it was the drive-by birthday party. But I also have a friend who's 77, and I was supposed to do a socially distanced cocktail with her last week. And actually she lives in Agora Hills and the curfew came down. So we never were able to do that. So we think at Senior Concerns, we think about all those seniors that are home, that are staying home, that are doing the right thing for their health and safety for the time being, but don't get to celebrate their birthday. So whether it is your birthday in June or you'd like to just celebrate some birthdays, come join us for a Zoom birthday party. That is going to be Thursday, June 18th at 2 p.m. And again, you could register for that one at info@seniorconcerns.org. Just tell us you'd like to attend and we'll send you the link. And I think that's everything. Let me see here that I wanted to cover. If anybody has another quick question and they want to put it in the chat section, I can do this. But we do have a lot of thank yous, Dr. Reyes, for in the chat section for your presentation. And so I think we'll end there. Everybody, please stay safe. And if we can help in any way, give us a call at Senior Concerns. Okay, thank you.
Thank you. Bye-bye.
Bye.
Bye-bye.